Good morning, everyone. I'm Cyril Harfouche from Naval Medical Center of San Diego, and I'll be presenting surgical telementoring. So our study was called Surgical Telementoring Using a Robotic Platform, Initial Experience in a Military Institution. All right, so before we start, we have no disclosures to report. And what is telementoring? So telementoring is the use of audiovisual technology to provide real-time assistance and guidance from an expert surgeon at a different geographical location. As you can imagine, this is going to serve us a great purpose in the military, given how fast and wide our network is around the world. Our hopes of the study were to expand the surgical expertise and improve the quality of patient care we offer within the DHA. By doing so, we hope to enhance the military's ability to deliver care to smaller, more remote hospitals and austere locations. This also allows us to improve training and mentoring opportunities for military surgeons, as well as minimize the limitations of geography, spatial, and situational factors. The military health system has long recognized the value and strategic importance of telehealth services and the medically ready force and the developing of the ready medical force. Remote presence and ultimately telesurgery are promising solutions to the growing challenge of maintaining workforce competency and patient accessibility in the setting of rapidly evolving surgical technology. Okay, so by design, all of the Da Vinci surgical systems are telesurgical systems. Even though the consoles are in the room, they technically don't need to be. They are just there because of current regulations and legal reasons by the FDA. So telecommunication-enabled medicine in the operating room has been well studied and established in civilian settings, and it demonstrated to show similar results as direct in-room mentoring. There's many advantages to that working in a military health system, and that includes the lack of provider competition, ease of privileging, decreased medical legal ramifications, as well as the emphasis on enterprise-wide capabilities. Now, in commercial settings, there's many barriers that include patient safety concerns, legal liability, surgical credentialing, economic reimbursement for services, and the presence of a standard platform for adoption and integration of all these services. And luckily, in the military, a lot of these barriers have been bypassed for us already. So our objectives were to adapt a well-established platform to allow telementoring through the robotic consoles. By doing so, we hope to demonstrate the reliability of connectivity and latency between the remote surgical consoles, which were located in our virtual medicine operations centers, and the operating room robotic consoles. And this basically serves as a proof of concept that shows the communication between the mentor and surgical team was effective and provided the mentor full immersion into the case. Now, our methods, so this was an IRB-approved protocol. Patients did not need to be consented prior to the start of the operation because they were receiving care from a fully board-certified surgeon, and the mentoring surgeon wasn't necessarily impacting the quality of care that they were receiving. They were merely communicating with the surgeon to test the audiovisual connectivity. This was conducted over a 5-month period, and surgeries included the fields of general surgery, urology. We had some thoracic surgery cases as well as gynecologic surgery cases. The mentor, Dr. Wisbach here, was stationed remotely. For part of the operations, he was in the virtual medicine operations center, in which there is a remote robotic console through which they communicated. And we also were able to establish a connection through our Ethernet network, which he was able to communicate with the teams from his office as well. This is Dr. Wisbach in the VMOC Center. Now, our methods, the operating room staff were all given a briefing prior to the start of the operation. All of the surgeries were kind of pre-enrolled looking at the operating room schedule, and the staff were administered a 6-question anonymous survey to be filled out pre- and post-operatively. This was a Likert-based scaled survey, and it was a qualitative assessment of team feedback, session effectiveness, and the reliability of communication. Next, this is Dr. Wisbach in his office. This is the technology through which he was able to communicate with the teams, which were in the operating room. And I'll talk a little bit about that in our conclusion. But so this is the survey we had up. And basically, it measured the effect on the range of surgical services offered, the satisfaction of the team with the quality of telementoring they received, whether or not they thought this would have an improvement in patient-reported outcomes, whether the surgeon established a pre-existing relationship and expectations, and whether the reliability and connectivity of audio-visual connection was good or it could have been better. And then the last question addressed whether the respondents thought leadership support will be an obstacle or influence on this study. So talking about our results, we had 86 survey responses. There's 43 pre and 43 post-surgery. This was on 15 operative cases, 7 in the field of general surgery, 3 urology, 2 gynecologic surgery, and 3 thoracic surgery. And it showed that the participants had a positive effect on the responses in regards to all questions that were surveyed. The participant perception of the leadership and administrative support question was varied. And in conclusion, so we were able to prove that surgical telementoring was effective and reliable in a multi-specialty single institutional model. The current technology allows for reliable audiovisual connectivity between the main operating room and remote participation in the same facility, and that was either through the virtual medicine operations center or anywhere else in the hospital. And this is a proof of concept for the potential role this technology has to play in improving patient-reported outcomes and the capability of expanding the surgical services we offer within the military. So what are the future applications of this? And that's really, this was a demonstration done by Dr. Wisbach for the DHA and ACS, and this shows the tele-illustration and tele-robotic instruments done on the Da Vinci console. So he was able to demonstrate through the surgeon remotely the tele-illustrations and the new instrument technology that's virtual done by Intuitive. We also were able to do some demonstrations with the fields of ENT and ophthalmology, where they were able to use that same exact technology to demonstrate the view from a laryngoscope as well as an ophthalmoscope. And we even were able to do that through cameras in the operating room and the ceiling on open cases. So these weren't part of the study, but that's kind of the direction in which we are heading. And some acknowledgments. This is Lieutenant Ferris. His work was essential to this study, all the way from Djibouti. This is our works cited, and I will now take any questions.